Good afternoon, everyone. Thank you so much for joining today's webinar on strategies for HCV testing and linkage to care in and from prison. And apologies for starting a couple minutes late. We started having some technical difficulties, but hopefully we have figured those all out and it will be smooth sailing moving forward. My name is Alyssa Kitlis, and I'm a manager on the hepatitis team at NASTA. And for those of you who aren't familiar with NASTA, we are a nonprofit association that supports state and city health department HIV and hepatitis programs through capacity building assistance and advocacy and policy work. And all of our work is done through the lens of social justice and the ultimate vision of seeing a world free of HIV and hepatitis. And we're convening this webinar today through one of the coalitions that we run. It's called the Hepatitis Testing Partnership, which is a coalition of stakeholders such as public health, providers, community-based organizations, academia, and industry who are working together to increase hepatitis testing and linkage to care in the US. And we convene this group both through an active listserv and through quarterly webinars like the one you're on today. And this webinar actually is the second part of a conversation that we started in June. That webinar was focused on testing and linkage to care from jail. And this is going to be similarly focused, but expand more on prison populations. And we're having this call because HCV among incarcerated populations is a topic that keeps coming up, both in terms of the need and the challenges, but also the incredible opportunities that we have right now in addressing this, particularly as we start to think about elimination. So as most of you know, incarcerated or formerly incarcerated individuals bear a disproportionate burden of HCV, with current estimates putting the prevalence in jails and prisons anywhere between 12 and 35%. And despite this high prevalence, most inmates with chronic HCV are unaware of their status. So it's really critical that we are testing and linking people to care, both for their individual access to healthcare, but also to think about reducing transmission and ultimately working to eliminate hepatitis C. So we're really grateful you are all here joining us today and continuing this conversation. And I'm going to be co-hosting this webinar with my colleague Mandy Altman, who works at the Hepatitis Education Project and runs the National Hepatitis Corrections Network. And I'm going to give Mandy a chance in a minute here to introduce herself and to tell you about the network. But before doing so, I wanted to go over a few housekeeping items. So the webinar is being recorded, and all attendees are on in listen-only mode, which means you won't be able to speak, but you'll be able to share any comments or questions that you have in the chat box. And I really just encourage you to use the chat box rather than the question box, because that way everyone on the line can see it and it can be more of a conversation. And if you send questions, it'll go only to me, and I'll have to try to get it out to the full audience so that way they can see the questions. But just something to note there. And then we'll be having a portion at the end, hopefully about 10-15 minutes, to do Q&A and discussion. And this webinar is being recorded, and you'll be receiving a link to the recording as well as the slides following the webinar. And we'll also include an evaluation, because we really want to hear both what you think about today's webinar, but also topics you'd like to see moving forward through our work, both through NASA's Hepatitis Testing Partnership and HEP's National Hepatitis Corrections Network. So before I introduce the speakers, I wanted to check in and see who's on the call today. So if you wouldn't mind, I'm going to open up a poll. I wanted to see where you're coming from. So the options are if you work at a health department, community-based organization, federally qualified health center, Department of Corrections, or other. Unfortunately, this platform only allows us to use about 5 options. So if you're part of the other but want to share where you're coming from, feel free to include that in the chat box. I know I saw a lot of national partners and federal partners on the registration list, so apologize for not including you there. All right, I'll give it a couple more seconds. It looks like most of the group has voted, so appreciate you sharing. All right, well, We'll share the results. So it looks like the majority of the people on the call are from health departments, but also a lot of others. So like I mentioned, if you wanted to share your organization or your agency that you're joining from, feel free to do so in the chat box. And I'm grateful to see a number of partners from departments of corrections, as well as community-based organizations and federally qualified health centers. So thank you for sharing that information with us. I'm going to figure out how to hide it. Okay, perfect. And sorry, I'm trying to do two things at the same time, and it's not always as easy as I think it is. Great. So as I mentioned, I'm co-hosting the webinar today with Mandy Altman, who runs the National Hepatitis Corrections Network. So before we introduce all of the speakers, I wanted to turn it over to Mandy to tell us a little bit more about her work in the National Hepatitis Corrections Network.
Thanks, Alyssa, and hi, everyone. Again, my name is Mandy Altman. I work at the Hepatitis Education Project in Seattle. And I want to thank everyone for joining today's call, and also to fellow panelists for being on the call. I appreciate that. So I just wanted to give a very brief overview of what the National Hepatitis Corrections Network is for anyone who doesn't know. NHCN is an organization that's been around for about 7 years ago, and it's an initiative of the Hepatitis Education Project, which is a Seattle-based nonprofit organization that's been around about 25 years. And it's a group that is basically just a network of people with an interest in hepatitis C in correctional settings. We use a public health approach to hepatitis prevention, testing, treatment, and linkage to care and harm reduction education in prisons and jails. Our network partners include correctional administrators and healthcare providers, with researchers, legal and policy stakeholders, with community-based organizations, and health educators. We serve as a hub of resources to provide information about hepatitis C in prisons and jails. We try to track the trends in hepatitis prevention, testing, and treatment. We maintain a website where we share news. We have a database of a lot of network partners across the country that we use to share information with and connect people with. We like to provide a forum for discussing best practices. We have several webinars a year, such as this one. We have newsletters that we send out a few times a year. And we like to develop and produce as much educational materials as we can for folks who are incarcerated, or those like those on this call who might need some resources to share with people in your community. We'd love to help on projects like that. So if anybody has, things related to hepatitis and corrections and they don't know who to ask, we're a great source to just put it over to us. And if we don't know exactly the right person, we can send a blast out to a group and get some information. We also have an annual meeting that is in March every year, where a group of usually around 75 to 100 professionals who work with hepatitis in correctional settings come, and we always have a very full day with a big agenda with a variety of speakers. It's a great time to network and get up to date on the trends in such a rapidly changing field. So if anyone's interested, you can go to our website. It's hcvincorrections.org. There's information there on how to sign up. You can also just send me an email. It's mandy@hepeducation.org. I'm sure Alyssa can send something out. And if anybody has any kind of questions they'd like to ask me, please feel free. Or if there's anything that NHCN can do to help support your work, please feel free to let me know. Thank you.
Thanks so much, Mandy. So now I'm going to do a brief introduction of all of our speakers. We have the pleasure to be joined by three really excellent panelists, most of whom I actually met at the National Hepatitis Corrections Network meeting. So just a testament of the power of bringing everyone together and creating that space for people to share what they're working on and brainstorm strategies for overcoming some of the challenges we face. So today we're going to hear from Laura Magaldi, who is the Viral Hepatitis Program Manager at Philadelphia Fight. She's going to get us started. And then after Laura goes, we're going to hear from Ann Chalkwin, who works at the Oregon Department of Corrections. She's the Health Promotion Program Coordinator. And I will just note we're having trouble finding Ann. She is struggling to log in, so we might adjust the order depending on if we can get her on in the next 10 or so minutes. And then last but certainly not least, we'll hear from Anna Steiner, who's the program manager at the Transitions Clinic Network. And then we'll wrap it up with some Q&A and discussion. So I'm going to turn it over now to you, Laura, to get us started.
Thank you so much. Hi, everybody. I'm Laura Magaldi at Philadelphia Fight. There we go. I think here come my slides. I work with the See a Difference program, which is the hepatitis C testing and linkage program. I think that this slide might be a little bit weird. You might have to advance through. There we go. We work on CURE here at Philadelphia Fight. We have 4 health clinics, the Jonathan Lax Treatment Center, John Bell, Broad Street Ministry, and Youth Health Empowerment Project. All providers at all sites will treat for Hep C. We do a ton of community-based testing at drug treatment programs, homeless shelters, MAT centers, and anywhere else where we might be needed. We've done senior centers, health fairs. And then we also work really closely with the Institute for Community Justice here at Philadelphia Fight. They do a lot of re-entry services, and they work very closely with the Philadelphia Department of Prisons. Some of you may be familiar with their work in HIV testing and linkage to care within our jail systems. Next slide. I wanted to start off, I don't know if this will be actually news to anybody on the call, but I think this is a great slide, and I love to share it anytime I can. It's really showing where the hepatitis C is living here in the United States. Of course, the baby boomers represent 75% of those living with hepatitis C and 78% of the deaths. Also, 6.7% among HIV-positive MSM who do not inject drugs, and 40% among those who do. The migrant community, we're seeing a seroprevalence of a little bit over 2%. And then, of course, the HCV prevalence among PWID, the people who inject drugs, is estimated to be about 70 to 77%, and probably a little higher. And that really ties in with our work with the people who are in prisons and jails, because we all know that there's so much drug crime right now, and people are just being shipped into our jails and into our prisons. It's such an alarmingly high rate rather than going to get some treatment. And we're seeing that the prevalence in corrections is estimated to be between 10% and 45%. Next slide. We do believe that testing is the first step on the path of elimination. We know that primary care providers should be following at least those CDC guidelines for testing, if not testing every single person who walks into their practice for hepatitis C at least once in their life, and more if they're living at risk. For those folks who cannot or do not seek primary care, we really believe that community-based testing programs are needed to reach those at greatest risk for HCV. And then, of course, HCV testing in jails and prison is necessary to reach those who may not be seeking primary care or community-based services. We know that when people are out and when people are home, they're not prioritizing their health. So if we can catch folks when they're in jails and prisons and get folks cured, when they come home, they're all better. We don't have to worry about them transmitting the disease to their loved ones. We do really believe that prison health is public health. And if we're not taking care of our folks who are inside prison and jails right now, we're not really taking care of those who are outside either. Next slide. Just a little bit of the background here. The John Bell Health Center, which is where the See a Difference team is primarily serving our folks. We provide a safe space for people to come for their primary medical care. We don't really care whether or not you have insurance. We don't really care whether or not you have an ability to pay. If you have an address, if you're street homeless, if you're kind of just couch surfing. And one of the things I'm particularly proud of is once our people come in, once our patients come in, they always say how much they love it here. Our providers are so compassionate and so wonderful, and they just make people feel like people. So we thought that that would be great to tie in. This is a great place to do all of our services and tie in the work that we're doing in corrections. Next slide, please. Our community-based testing is all over the city. We're really special in that we do reflexive testing out in the community for every antibody positive result that we find. Whether we find somebody who already knows their antibody status because they're tested as a part of their recovery program, or if we're doing rapid tests, we immediately pull out a phlebotomy kit and we draw that blood, and we get people, we get their results back to them within 72 hours, so they know whether or not they have a chronic infection. We have enhanced linkage and social support services for those found in community testing sessions. We do targeted testing sites such as recovery and re-entry programs, and we also meet with everybody who may have their hands on our patients at those testing sites, just to be sure that everybody is getting taken care of the way that they should be. Next slide. And another word about ICJ, it's the Comprehensive Prison Service and Reentry Program. We have the Reentry Center with educational programming, community and civic engagement, and advocacy. We have our prison linkage specialists who make sure that everybody who walks in there gets the medical care they want or need, make sure that they are being advocated for in court, make sure they have health education, social support, and also discharge planning support. They'll actually go inside of the jails and make sure, in prisons, and make sure that everybody knows what kind of services are available once they're out, especially folks that have been in for long-term placements. They might not be kind of up on what programs are out there for them once they return home. Next slide. So our corrections testing program began really 5 years ago. The talks, and maybe even more, the talks began kind of among our peers about the need for hepatitis C testing within our jail system here in Philadelphia. We worked really hard over the last 4 or 5 years. Dr. Truskin, who I work very closely with here at Philadelphia Fight, and I kind of set up our program and all of the services surrounding our program to be able to receive folks who are coming out of jail and prison who are hepatitis C positive. So we've been working with Gilead Focus for the last 4 years, and we felt it was time to ask for their help in supporting our testing ideas and testing programs in the Philadelphia Department of Corrections. Our grant year started in October. We thought that we'd be up and running and testing by January, but as you all probably know, that's not always the way it works. October, November, and December was really just kind of orchestrating our team. Then we were surprised a little bit how slow things got started. January, February, and March, we still weren't testing. We were doing extensive Hep C education to the prison medical staff, and we were just passing contracts between our city and Philadelphia Fight back and forth. We hired that linkage coordinator through ICJ. And we worked on our inclusion criteria and our testing protocols to make sure that the needs and also concerns of the Philadelphia Department of Prisons were met. Of course, they were worried about finding a ton of positives and having to treat them and what that would look like. I should say here that the Philadelphia Department of Prisons is really our jails. They're short-term. I don't know why they call them prisons, but they are a county jail system. In April, we finally all agreed that folks should be eligible for testing 6 weeks prior to their release. They were tested by the prison medical staff in the presence of our linkage specialist. So they really wanted to make sure that the proper education information and everything else was kind of overseen by our folks before they let anybody be tested without our folks present. What we were finding, though, is that people weren't even making it to 6 weeks prior to their release. They were getting released early, and they weren't getting tested, so our numbers were super low, maybe like 12 or 13 people out of the 20,000 people who were up on State Road, where our jails are, were tested in April. In May, they backed that up to 6 months prior to release. They were still tested in the presence of our linkage specialist. And we were doing better, but not as good as we should have been, and definitely not up to our funders' wants and what we told them we thought that we could do. And then finally, in August, we were granted the ability to test all sentenced individuals in jail for hepatitis C. And then in October, they let us take our linkage specialist out of that testing session, and that allowed her to go and meet with the people who were positive, so they knew the resources available to them upon release. Next. Again, just to say how wonderful Philadelphia Fight is to do this kind of work. Part of the mission of the John Bell Health Center is to serve returning citizens. A lot of the folks that were tested up at the Department of Prisons are currently now patients of the John Bell Health Center, or were previously before their incarceration. So they can come here and see the doctor that they've always kind of seen, or that they've seen once or twice. And we have pretty good patient records for a lot of the people who we're finding up on State Road. ICJ is located 1 floor below the John Bell Health Center. We're right in the same building. Individuals can visit both in the same day. Our patient navigators will take somebody downstairs to ICJ if they know that they came to the clinic first, and if somebody comes to ICJ first, their staff will bring them right up to the health center. And then several of our community partners and testing sites serve those who have been recently released. So our staff, they split time between the jails and the recovery and reentry centers. Next slide. Our linkage services are whole person oriented. We know that not everybody is ready to start their meds right upon release. So we have social services, medical case management, behavioral health services. We have dental care, pediatric and adolescent clinics for people who have children, and also for folks that are infected with HIV as well. We can do primary care here for them. They can go to the Jonathan Lack Center if they would rather somewhere that's completely an HIV primary care place. And the Hep C care is individualized and carefully tailored to meet the needs of each patient. We have a multidisciplinary approach where our social workers and our case management and our testers and our doctors and nurses and pharmaceutical staff all meet every single Friday to talk about every single patient. Again, we provide care regardless of citizenship, sobriety, or insurance, and harm reduction care models are practiced at each clinic. So when we see our patients, they leave here excuse me, with a Narcan kit, a Narcan training, with information about Vivitrol, with information about recovery programs, and other support services. Next slide. We partner with the Department of Prisons. We work really closely to make sure that as many people are tested as possible. They share the results with us each week so we know who we need to see up there. And then we also work really closely with the Philadelphia Department of Public Health surveillance team. Sometimes folks fall off the radar or the results don't come in time, and they really help us with just knowing where people are, whether or not people are positive. Next slide. Challenges, it gets a little bit unwieldy. Getting people from their cells down to medical can be timely and just almost impossible, it seems sometimes. Sometimes it goes really smoothly, sometimes not. There's different staff and workflow at each of the 5 facilities up on State Road with our jails. And then a lot of times the inmates are often released prior to testing. Another complication that we had was that the tests are performed by the jail, so an outside agency with a lab that's new to us, so we don't have a rep from there or contacts necessarily. And all of our data is recorded, housed, and disseminated from an outside agency. Next. Then our successes, we're really proud of the work that we're doing. We're really working to get all sentenced inmates tested. We've done a lot of staff education and relationship building between Philadelphia Fight and the jail system. We are making our official visits. We're meeting with every single hepatitis C positive inmate if they want to see us and let them know what we have to offer them upon release. All of our linkage staff has prior experience working in the jails, and so they know the faces, they know the sites. We have a lot of internal champions between the providers, the peers, the lab staff. They're all encouraging folks to get screened and accept linkage. There's a really positive, we actually have to turn people away for testing sometimes because they're not yet eligible, but people want to get tested and they want to talk to our linkage folks. And then we know that the recidivism rates are high, which of course is not the best news, but we use that to our advantage. So folks that leave before testing are testing upon reentry, and folks that are lost to care, hard to contact, we find them when they land back up in jail, and we get them back into care. So our future plans are PSAs in the prisons to increase the educational reach, and also routine opt-out testing for everybody who enters our jails. Next slide. And thank you very much. There's my contact information. I'm at my desk most days, so you can usually reach me by phone and also email with any questions. Thank you so much, everybody.
Great. Thank you so much, Laura. I really appreciate that overview. And now we're going to see if Anne is able to speak. It sounds like she would join, but I don't see her on here. So Anne, can you talk and can we hear you?
I can. Can you hear me?
Oh, yes. Amazing. Perfect. I'm so glad we worked that out. Great. So now I'm going to turn it over to you to tell us about all the great work you're doing in Oregon.
Wonderful, thank you. I just want to start by saying what a wonderful presentation by Laura. I want your social workers, your linkage specialists, and your educated providers, please send them my way. It just sounded like such a gift. But I will tell you
Great.
all, I'll tell you all what's
We're very
happening here in Oregon, and I have to
progressive.
say we're pretty blessed. So if I could have the next. Oh, and I can't see, so there it is. So the overview of Oregon Department of Corrections. We have at any given time about 15,000 people who are incarcerated in any given year. This fluctuates, of course. We have about 400 people coming in, 400 people going out at any given time. We have 14 institutions across the state of Oregon, which in some places is very rural, as many of you may know. We have a centralized intake center for the women on one end and the men on the other. We have about a sero study from 2005-2006 showed us that we have approximately 0.08% HIV positivity. Low for high incidence states. We are a low incidence state, so this is a little bit above Oregon's general population percentage. We have theoretically the same chronically B positive as HIV low. However, we do know that hepatitis B is an issue in Oregon, or was before we did some amazing Twinrix vaccine work with Jude Leahy and the rest of the Oregon Health Authority group. We also know that we have, again, from the sero study and some other evidence here in Oregon, that between 25 and 30% of HCV positivity. What that means is at any given time, between 1 in 4 or 1 in 3 individuals in our prison system is positive with viral hepatitis C at various stages, whether they know they're positive or not, whether they are far progressed or not. So that's kind of the landscape. I also just want to mention we are seeing similar to the national trends in younger individuals testing positive. So that under age 30 cohort is definitely alive and well in Oregon's prison system, which is really unfortunate, but also gives us some opportunities for some increased intervention, which I'm going to talk about now. So next slide, we have something called health promotion programs here at Oregon's prison system. And I'm telling you this because it's important to get the landscape of how we do what we do when we talk about hepatitis C. We have intake risk reduction education that addresses bloodborne pathogen transmission, the risks inside, as well as the risks that one may have participated in prior to incarceration. This gets people's juices flowing, thinking about, oh my gosh, did I put myself at risk? And then at their home institution, so when they settle in a prison, granted, they may move prisons over their tenure, but at the time of entry into the home institution, we have peer health educators who do what's called admission orientation, and we talk to them about getting tested and doing a variety of programs that may help them in increasing their overall health while they're in prison, hopefully learning skills to take that healthfulness to community. The first one that we're really very proud of is the Hepatitis HIV/AIDS Awareness Program. This was started by four inmates back in the mid-90s. We have developed it into a peer education program that is manualized and evidence-based across our system. One does not have to have any communicable disease to be in that program, but what that does is it helps us educate a cadre of peer health educators so that they can do communicable disease education on the yards, on the tiers, and the chow line, etc., places where we can't reach. And we all know that peer-based education is the best education when it comes to marginalized populations. The reality is we know that people who learn from professionals do more, but people who learn from people like themselves, people who learn from professionals know more, but people who learn from peers do more. And that's what we're looking for here. So we also have the self-management skills for living well, again, just building those toolboxes. Aspire to a Healthier You is a nutrition exercise program, something that all of our folks love to participate in. It helps people learn how to eat a little bit healthier, and we know that people living with Hep C in particular and HIV certainly need to take a look at nutrition as a way to manage either their symptoms or how the liver's functioning. We're implementing a new program soon called DEEP, the Diabetes Empowerment Program, but what we're really here to talk about today is testing. We do counseling, testing, and referral for communicable diseases. We do not do opt-out testing. And I get a lot of questions as to why we don't do opt-out testing in our prison system. Next slide. And the main thing is that our intake center does not have the infrastructure to sustain the needs related to a positive communicable disease diagnosis, meaning people are just coming into prison. They are freaked out. They may be on short stints or long stints. And that in and of itself, and having all your rights taken away, I find it very, very important to ensure that our population is educated and supported in making empowered decisions to know their HIV and hepatitis status if they don't already. Meaning we really value our patients making that decision for themselves when they're ready. But don't get me wrong, everything I just talked about in the previous slide, from intake risk reduction to our HAP class to A&O, admissions and orientation, each institution, those are the mechanisms by which we hit hard and heavy the health promotion around getting tested, know your status. So if at intake someone is interested in knowing their status, we put them on a list, we track them to their home institution, and we get them tested as soon as they reach their home institution. So while we have opt-out testing, we have multiple mechanisms to support people in engaging in knowing their hepatitis status while incarcerated. It's sort of our primary focus, if you will. So our counseling, testing, and referrals, what CTR stands for, next slide. We still use the 6 steps of client-focused counseling. Now, there's been some recent suggestions that those 6 steps may be antiquated, et cetera, but what we find in prison is that using those steps, orienting the client to the session, determining risk, a variety of other things, it really enriches the dialogue with our health promotion contractors. I have contractors in each institution that do confidential testing. Granted, it goes into the medical chart, but any of the risk behaviors they may have participated in are quite confidential. These are contractors, not staff, so there's a little bit different feel for them. And it really, using these 6 steps really helps people engage in a way that they might not otherwise engage. So they're maybe more willing to talk about some risks that they're concerned about, even if they don't divulge risks that they're currently taking. And the contractors are well-seasoned veterans in the harm reduction field, the A&D field, lay medical field. They're really an amazing cadre of professionals. So they engage these folks in not only testing, but also inquire with them as to if they'd like to learn skills, some other health-related skills in our other programs, all leading back to leaving prison healthier than when they came. We also know that using these 6 steps of client-centered counseling for counseling, testing, and referral, which we do in Oregon's prisons, enhances patient education and relationship building. That way, if someone should become positive or get a new positive during their tenure with corrections, they come to these contractors who run these health programs and talk about strategies for maintaining safety, strategies for reporting or disclosing to other individuals, where in prison, disclosing may not be their best choice, or depends upon the culture, it may be more supportive. For example, you all may know that while hepatitis C in prison is pretty okay to have because of the variety of mechanisms one can get it, mostly injection drug use, HIV is still very highly stigmatized in prison. So there's a variety of cultural contexts we have to take into consideration here. Next slide. So treatment, or what I like to call treat to cure, inside prison. Because we have a cure, yay, those of us who've been in this field for a long time probably still daily do a happy dance on this. What just occurred in Oregon was our advocates, working with our tenacious public health professionals, went to the Pharmacy and Therapeutics Committee of our Oregon Health Plan and asked them to remove restrictions on treating people with Hep C. So what does that mean for corrections? Those restrictions were removed, by the way. So staging, use, a variety of other issues alleviated as far as barriers to HCV treat to cure. What that means for our prison system is, because we implement community standard of care and our policies mirror those of at least the Oregon health plans, then there may come a time when staging becomes less and less important. I can tell you that we have some amazing docs here in DOC who are treating people. Our infectious disease doctor, Dr. Dan Dusnip, is one of the most wonderful docs that I've ever experienced, and he has a passion for treating to cure the population that we serve. And our medical director, Dr. Chris DiGiulio, is on board with that as well. So we are very fortunate in Oregon's prison systems. I know this isn't the case around the country, and y'all may have prison envy at this point, but I have to tell you, we are so blessed to have these docs. They get it. They realize that good public health inside means good public health outside. So we're looking at what that new community standard of care may mean for corrections. What it probably means is more people will get treated as the budget allows, and we're very, very excited about that. But what about people who, for whatever reason, are not going to get treated in prison? The linkages to care, aka treat to cure, next slide, in community. So persons, right now we have one release nurse for medical high acuity patients. That means people who are paraplegic, quadriplegic, demented, all kinds of really high acuity health issues. We have one specialist who oversees those releases. While there's 400 releases each month, a small proportion of those are indeed those high acuity releases. So she doesn't necessarily have the time, energy, or bandwidth to support people who are asymptomatic leaving with Hep C. It's like, you're leaving with diabetes. We want you to have this under control. Best of luck. So we know that we have a good community-based infrastructure to help with transitions for people living with HIV. We are all still blessed in the era of, the waning, possibly era of Ryan White, that we have good community linkages for people with HIV. What do we have for Hep C? Well, unlike perhaps some other places, we don't have an amazing linkage service. This is just not something that the infrastructure supports either in community or inside. We do our best, we, the health promotion folks, me and my shop, to, as well as, the nursing staff, et cetera, to support people in identifying where they're going to garner their medical care upon release. However, the transition coordinators or the release counselors, that is not their job. Their job is to find housing, supported housing, work, other necessities of daily living. A diagnosis of Hep C, particularly which is asymptomatic, does not fall on folks' radar to assist people with on the way out the door. Now, again, my cadre of health promotion contractors and myself, if people are going to the largest counties, we can refer them to the providers in those counties that we know are really good, who will work with people on Oregon Health Plan, who will work with marginalized folks. However, we don't have bridges. We have pathways, but we don't have bridges to community. So we're really hoping in the future to be able to do hot handoffs to a transition clinic. The next talk will speak about transition clinics, and I just have to tell you that is my dream of all dreams, is to have a transition clinic here in Oregon. Anybody who knows me knows that. We do have some state targeted response opioid grant funds that are allowing us infrastructure development for pathways to community for people living with opioid use disorder, not the least of which will hopefully be some pathways to Hep C treatment. And then we like to have ongoing dialogue with our community partners that enhance these pathways to care. So whenever there's an opportunity to speak at an organization who does community-based Hep C treatment, we're there. We're at the table. We love our community partners. Our health authority partners are wonderful, our nonprofit partners. But we have to expand into more rural areas of the state to capture the largest proportions of our population, because people are leaving and they're going into areas of our state where there isn't even a hepatitis C treater. So we have to do more. And part of that, again, is that community linkage and collaboration. So as a former adult viral hepatitis prevention coordinator, I know the value of community linkages and really building partnerships so that our populations can get served. My dream, of course, like I said, next slide, is to have that transition clinic to prioritize HCV care, treatment to cure, and ultimately people who have concomitant substance abuse treatment. This is the way, I believe, when we treat people to cure with Hep C, we are engaging them in a manner that will help them engage with other systems and other services that will lead to a decreased likelihood of recidivism. Because once a person is healthier, per se, we firmly believe that they will be healthier in all their interactions, including criminality and other factors that support recidivism. So if you have any questions for me, next slide, there's my contact information. Please contact me by email or phone anytime. I just gave a brief overview of what we have. I really believe in our programs. I believe in our people. And if at any time I can be of assistance to you, please feel free to contact me. And now the next person is going to talk about what we all dream of, I think.
Thank you so much, Anne. I think, you're right. We all do have prison envy for the programs that you've set up. You've built a really great program there, and appreciate you sharing about your work in Oregon. And then thanks for setting up Anna's talk. As Anne mentioned, Anna's going to be sharing about the Transition Clinic Network and what a program focused on linkage and primary care, particularly empowering formerly incarcerated individuals, can look like. So I'm going to turn it over to you, Anna, to share about your work. And
thanks.
The dream that we all now have.
Anne, I appreciate that plug. I'm hoping to live up to this expectation. And I also just want to note that Laura, this is the first time I heard about the Philadelphia Fight program, and it's amazing. So I'm going to reach out to you too.
Thank you. Please do.
Yeah. So thanks to Alyssa and Mandy for organizing this webinar. My name is Anna Steiner. I am the program manager for Transitions Clinic Network. We support a consortium of primary care clinics that have implemented a program that's specific to serving people with chronic health conditions coming home from incarceration. And at this point, we've worked with 29 sites in 12 states and Puerto Rico. Next state, Oregon, Anne. That's what we hope. Next slide, please. Oh, go ahead, next slide. I have too many slides, I think. So I'm going to very briefly try to cover this in a few minutes. Just a brief background. I think everybody on the call probably has some good background on why there might be some differences in caring for patients with a history of incarceration, with or without hepatitis C. But I always like to do a little overview about that. And then I'm going to talk a little bit about our model of care. So I think it's important to just sort of set that up and why we developed this program. So next slide, please. So these next couple slides, pictures come from San Quentin, which is a state prison where I actually run a discharge clinic once a week. It's located in California. I think sometimes when I'm talking to folks, they think that people who are incarcerated are healthy and young. There's this sort of impression, maybe not people who are doing this work continually, but we know that up to 85% of individuals who are incarcerated have some chronic health condition that requires longitudinal primary care. And in addition to obviously higher prevalence of Hep C, there's a higher prevalence of almost every disease among the incarcerated populations. Next slide, please. Oh, back one, please. So while there is, and I do have some prison envy about Oregon. California is doing some incredible things too, but I always just want to reiterate that it is prison, right? There's a constitutional mandate to receive healthcare services, and there are just some things about being in prison that can really be detrimental to people's healthcare. I think of note with this picture is we really see sometimes people participating in high-risk behaviors that they may not participate in the community, just due to lack and limited access to things that you have in the community. And when we think about hepatitis C, I think we all probably know that the most common way for it to get spread within prisons, which happens very, very often, is through shared syringe use. So I just think people will we know that people will engage in more higher risk behaviors while incarcerated due to this limited access. Next slide, please. And I think it was, maybe it was Laura who said prison health is community health. We firmly believe that, not only because, we believe in everybody's right to be healthy, but 95% of people who are incarcerated in prison will return to the community. So really they're returning to our communities. These are our families, our friends, and our neighbors. Next slide, please. And some of the challenges, so I think when we're thinking about people coming home from prison, there are some unique challenges that have been highlighted. I think Anne had some great, had highlighted a few of these, but I just want to make sure to run over these. I mean, there is no discharge planning generally in most prison systems. There might be for HIV and severe mental illness, but certainly as Anne highlighted, I've never seen really a comprehensive program for hepatitis C in specific. Most people don't get their health records when they come out, and have very, very short supply of medications. Health insurance tends, if we're lucky enough to be in a state that expanded Medicaid, people's Medicaid will get turned off if they're in for over a year. So most of the time people are released without any insurance. So any needs that they need taken care of, there's really a barrier to accessing care as far as insurance even goes. And on a systematic level, I would be remiss not to mention that there are 30,000 just collateral consequences that follow people into the community. And that means that once people have served their time and actually served out their prison sentence, there are things that follow them throughout their lifetime that really impact their ability to receive services and prioritize healthcare. I mean, I always like to just sort of, it's amazing to me that there's still in some states a full ban on food stamps for certain people who have certain felony drug convictions. So I just think when we're thinking systematically about ways that people have issues accessing care, I mean, we just need to think a little broader here. And then on an individual level, I think we can point out a lot of issues as far as why corrections makes it difficult to link people to care. But I think reflecting upon the community healthcare system, we've seen so much data showing not only discrimination against people of color and people from low socioeconomic status, which are, as we know, the people who are disproportionately impacted by the criminal justice system. But there's also been some research, and there's more research coming out about people feeling discriminated against in the community healthcare system just based on the criminal justice history. So next slide, please. So I think it's just important to note those things when we talk about why we created the Transitions Clinic Network and the Transitions Clinic program. There are other people doing great work too. Like I'm amazed, I'm really excited about Philadelphia Fight's emphasis on this population, because I think traditionally we've really just seen a lack of interest, or maybe just a lack of sort of acknowledgement from the primary care system, that there are so many people coming home and that they're really not getting their needs met within the primary care network. So the Transitions Clinic program started in 2006 in San Francisco and really was based upon us seeing individuals returning from prison accessing care at the emergency department when they should have been in the primary care system. And we did have a low-income health plan at the time, so it wasn't that insurance was the barrier in particular. But it was just that really that people didn't know how to navigate the system. So next slide, please. So sort of based on that knowledge, we worked with a number of like sort of traditional healthcare partners, and then also some amazing advocacy groups here in the community. So we worked with, it's called Legal Services for Prisoners with Children, which is a group that works with formerly incarcerated and currently incarcerated individuals. We worked with City College of San Francisco. We also worked with community members in our neighborhood here most impacted by incarceration to really think about how we could transform the primary care system into a system that is one that is based on responsive to the needs of individuals returning home. And I think Philadelphia Fight, I think Laura really highlighted some of these. All the sites we work with have individuals who are dedicated to working with this population as part of the primary care team. Most sites have integrated physical and behavioral health services, some medication-assisted treatment on site. Actually, just did a survey with our providers. Most of our providers, particularly all of our providers in California, offer Hep C treatment on site, and they all do also Hep C screening when they enter, because we know that this is such a high prevalence population. They are doing a really good job of screening individuals in the correctional setting, and they will be actually treating everybody in California State Prison. But all of our sites do actually do Hep C screening, and they all offer, and this is in California specific, where we have 8 sites, offer Hep C treatment on site as well. And then I think, we also partner with other community organizations like the Institute for Criminal Justice. We really try to make sure that our sites, our primary care sites, are linking people to the other services that they need to make sure that they stay healthy. And I think what we consider the really essential component of this model is that we engage what other people call linkage coordinators or case managers. But all of us sites, even though they're primary care based, employ somebody with a history of incarceration to work as a community health worker. And they really are what we feel like are the people who are able to engage people in care and keep them in care. So next slide, please. I'm just going to sort of scroll through these really quick. Our community health workers really spend 50% of the time in the community and then 50% of the time in the clinic. But they're able to do things like advocate. They can advocate for people. Before Hep C treatment was freely available, they would help advocate for our clients to make sure that they received treatment. They also advocate for housing. They advocate for all the things and help people link to all the services and care they need. So go ahead and go to the next slide and the slide after. And I know this is not particularly Hep C focused, so I'm sorry. I apologize for the sort of lack of Hep C focus, but I do want to I was just talking to a provider that we work with, and I really want to say that one thing that the increasing access to Hep C in primary care has really done for our sites and our clinic is we know that this is something we really educate our patients around, since the prevalence is so high, and many of our clients have been in prison for a really long time. Many have actually had interferon treatment that has not worked. And I think by building this capacity among primary care centers to not only offer people treatment for Hep C, but also to assist them with all the other reentry needs has really, the Hep C treatment has really helped us engage people and a different clientele than has in the past. And I've heard other providers talk about that too. So we really work very closely with the correctional system, and we believe in this sort of no wrong door approach. And while Hep C treatment is like one of many things we offer, I do think it's a really important thing that we educate our clinicians on, and are really pleased to be able to offer our clients now. And then next slide, please. And just briefly, just wanted to show that the program, we've been blessed to be able to work with 29 sites in 12 states. We've also had some data to show some really great health outcomes. And I'm just going to sort of breeze through the next 2 slides. Sorry, Alyssa. It's got very ambitious. So we've seen fewer preventable hospitalizations. We also have seen that people who are engaged in the program have fewer technical violations. So I think when we're talking about healthcare, we also want to think about recidivism. So that's always sort of the holy grail when it comes to that. And I just want to sort of skip to my last slide. Sorry, I know time is limited here. And I think, one thing, that I really wanted to talk about was how we could promote some systematic change moving forward, because there are a lot of really good things happening. I'm sort of amazed I'm saying this, but there are a lot of good things happening in the prison system right now. And I think Anne is a testament to that. And it really is, there are things that are changing. I think particularly when it involves around substance use and things that are related to drug crimes. I do think that this is a moment where we as healthcare providers and as health departments, and I know that's the majority of people sort of on this call, I think one of the things that we really talk about and think about a lot is, since we have this national network that seems to be growing, is how do we as advocates and as people who are interacting with this population and are in the privileged position to sort of amplify the voice of people who are incarcerated and formerly incarcerated, move forward and make sure people are getting treatment to Hep C, getting screened. These are just a few suggestions that I had and thoughts about what we could all do sort of moving forward. And I know many of us on the call are working on this already, but we really, there are things happening with Hep C treatment becoming the community standard, so we can really push the correctional system to increase Hep C, and also push the community. We're still seeing a lot of stigma among community providers in treating people coming home from prison, and also in treating Hep C in general. I also always wanted to say that, that there is a lot of criminal justice reform happening right now. We should be advocating that those dollars stay in the community and support things like Philadelphia Fights programs and our community health linkages. And I still dream big, and I say we should start advocating for syringe exchange in prison. We know many people are getting Hep C in prison, so I think that's another thing we can, as a network, sort of think about moving forward. And so next slide. So just highlighting the states that we are working in, and we are always looking to partner with other primary care clinics and just talk to other people who are doing the same work and passionate about this population. I'm sorry this talk was so rushed. When I practiced it was 12 minutes perfectly, and then I think I I got overly ambitious, but hopefully I was able to hit some key points. And my contact information is also at the end of this. So thanks, everybody.
Thanks. And Anna, I should be the one apologizing. I feel like I'm getting a reputation with these webinars with poor time management because I've never had the amount of time that I say we're going to have for Q&A. So I apologize, everyone, for that. But a few questions have come in, so I'm going to try to do kind of like a rapid Q&A. So for you, Anna, to go first, one came in around funding, and someone was wondering how the Transition Clinic Network or the transition clinics are funded.
That is a great question. I would encourage you to email me too. My email is up there. So the funding issues, and I'll keep this really quick, is generally the thing that needs to get funded that's difficult to fund is the community health workers. And we have all sorts of strategies, and there are all sorts of different mechanisms that people have utilized. All these clinics are co-located in existing primary care clinics. So generally things like physician time are in kind, and all the services are billable. And if you're in a Medicaid expansion state, 99% of people coming home from prison essentially are going to have Medicaid. So those services are billable. If you're in a non-Medicaid expansion state, we can talk because there are options. But definitely have some insight into how to fund community health workers too. So I think that's generally tends to be the main sort of ongoing expense that we are strategizing around sustainability. But it's a long conversation, so happy to engage. Anybody feel free to contact me. But
great. And yeah, there was another question about funding for case management and linkage. So I think rather than trying to address it in the last 2 minutes, it just highlights maybe a next part of this conversation could be focused specifically on funding, because I know these are newer programs in a lot of places and there aren't necessarily designated resources, and there's the need to be creative about that. So I will just say that we have noted that, and then also can follow up potentially on a future call or webinar. And then it looks like there's one question that might be pretty quick, so I'm going to ask it real quick. Laura, so for the Philly Fight program, when you communicate with RNA test results to clients within 72 hours, do you do that via text, phone call, or in person? And if you have any.
I think I can answer that quickly. We do that any way that we can. If somebody has a phone, we'll call them if they want us to call them. If they give us their email address, we'll email them to have them give us a call. We go out on foot, especially for those who are living on the street, and we say, has anybody seen Chuck? And they're like, yeah, he's around the corner, and we'll go deliver it face to face. So we're so blessed with such an amazing linkage team that is willing to do whatever it takes at every single step of the cascade. So basically we get those results to people in any way possible. And we collect a ton of information at the time of testing. So we want to know like where your mama lives, where you cash your check, where you hang out, where you work, just so we can find you after we part ways during the testing session.
Perfect. So I apologize. We're probably going to go over here a minute, and we started a minute late, but I just wanted to thank all of our speakers for your incredible presentations, and apologize for being a little rushed. And I think a number of really important points stood out. So hopefully you all got some ideas or some nuggets from this. I think for me, really just reminded me the importance of thinking about linkage to care and care broadly beyond just the specialists, and thinking about ways we can support people in all their many needs, and the importance of having people with lived experience as a really leading part of that puzzle. And so really appreciate you all for sharing about your work and all the different ideas for future calls and conversations. And so if you included anything in the chat box that we didn't get to, we will follow up with you either directly or maybe in a future call or webinar. And I encourage you all to take a couple seconds to fill out the evaluation to give us ideas for things moving forward. And I did want to quickly mention that under the handout portion of this platform, there's an article that Barry Zach from the Bridging Group shared. It's about different successful models for continuity of care and what they have in common on the HIV side. And I think they really reiterate and are parallel to what we heard today, and are things that we can think about in our hepatitis programs as well. So wanted to make sure you all knew that was available. So thank you so much for joining us today, and thank you to our speakers, and look forward to talking to you soon. And as we mentioned, we'll be sharing the recording and the slides in a follow-up email. So enjoy the rest of your week. Thank you.